Usually when we talk about a medical diagnosis, there's this expectation of precision. Like it feels almost like engineering sometimes.
Right. Very binary. Very clean.
Yeah, exactly. You get a patient with trauma, and the x-ray shows a jagged white line on the radius, and you just point at it and say, well, there it is. It's broken.
You fix the bone, you move on.
But then you step into the world of internal medicine, specifically renal and respiratory physiology. And suddenly that x-ray machine is completely useless.
Oh, completely. It's a totally different ballgame.
We're looking at a diagnostic landscape that is just murky. It's full of moving targets, and it relies heavily on, indirect evidence. You're looking at a crashing patient whose internal chemistry is completely out of whack, and their basic labs might actually be lying to you.
Which is, quite frankly, exactly the scenario that you, our listener, are training for right now.
Yep. We know you were deep in the trenches.
Absolutely. You are a PA student. You're probably burning through UWorld question banks late at night, just staring down the barrel of the pantsus. And we know acid-base disorders are notoriously intimidating.
Oh, they're the worst.
Right. But they are also completely crackable once you see the underlying mechanism.
So for this deep dive, we have a set of clinical notes here, and it's titled The Simplified Three-Step Approach to Acid-Base Disorders.
I love that title.
I mean, I do have to point out the dark humor in it.
Okay.
Because the document actually outlines 5 distinct steps.
Yeah, it's definitely 5.
And the last step involves, like, straight-up algebra. It's like someone promising you a simple 3-step cake recipe, and then on step 4, handing you a protractor and a Bunsen burner.
The irony is definitely rich. But, the stakes are very real. The math and the mnemonics feel super overwhelming when you're just staring at a screen of raw data.
Right. It's a wall of numbers.
But understanding this logically isn't just about unlocking major points on your boards. When you are out there in clinical practice, like rounding in the ICU or running a trauma bay, recognizing these patterns rapidly is quite literally what saves lives.
Okay, so let's start by establishing the baseline, because we really need to know what normal looks like before we can spot the chaos, right?
Exactly. Start with the basics.
The human body is ridiculously picky about its acidity.
Yeah.
The normal pH range is 7.35 to 7.45. That is an incredibly tight window for a biological system to maintain.
It is. And any deviation outside that tiny window means cellular function starts to degrade fast.
Right. So to evaluate that, you just have to commit the normal lab values to memory.
There's no getting around it. You know these, but let's recenter for a second. Sodium is 135 to 145. Chloride is 1 of 5.
And the bicarb?
Your bicarb, your HCO3, sits around 24 with a tight range of 22 to 26. PCO2 is 40, and a normal Anger gap is 10 to 12.
Okay, which brings us to step 1 of our clinical pathway here. Identify the apparent disorder by just looking at that pH.
Right, the easiest step.
Greater than 7.45 is alkalosis. Less than 7.35 is acidosis. Straightforward enough, but, I've seen the tricky practice questions that try to weaponize this first step against you.
Oh, the board examiners love doing that.
Right. You get a patient who is clearly in distress. They're tachycardic, hypotensive, altered mental status. But their pH is chilling right at 7.40. Right in the dead center of normal.
It feels like a trap.
It totally feels like a trap to just select normal and move on to the next question.
And it absolutely is a trap. A completely normal pH in a critically ill patient is a massive red flag.
Wow, really?
Yeah. If the pH is within the normal range, maybe high normal at 7.44 or low normal at 7.36, but the PCO2 or the bicarb are wildly abnormal, you are looking at a fully compensated disorder.
So the body is basically fighting a hidden physiological war to keep that pH at 7.40, even if it means throwing every other chemical balance out the window.
Exactly. The body will sacrifice literally everything else to keep the blood pH survivable. So if the pH is normal, but the other values are off, you still have a massive disorder to diagnose. You can't just stop.
Okay, so we check the pH and we declare acidosis or alkalosis. Now we need to find the culprit.
Right. Who's to blame?
We know the blood is too acidic or too basic, but is it the lungs driving this, like a respiratory issue? Or is it the kidneys making it a metabolic issue?
And that's where step 2 and step 3 come in. They are entirely about analyzing the PCO2 and the bicarb to answer that exact question.
And the ultimate pants-as cheat code for this is the Rome mnemonic, right? R-O-M-E.
Yes, Rome is your best friend. Respiratory opposite, metabolic equal.
Okay, let's look at step 2 then. evaluating the PCO2?
So PCO2 is driven by the lungs. Under the Rowe mnemonic, respiratory opposite means that in a primary respiratory disorder, the PCO2 and the pH will move in opposite directions.
So if the pH is low, meaning acidotic, and the PCO2 is high?
Right, opposite directions. That means it's a primary respiratory acidosis. The lungs aren't blowing off enough CO2, they're trapping the acid.
Okay, but what if they are going in the same direction? Let's say the pH is low, but the PCO2 is also low.
Ah, well, that tells you the lungs are not the problem. They are the reaction.
Oh, I see.
Yeah, if the PCO2 moves in the same direction as the pH, it represents respiratory compensation. The lungs are hyperventilating to blow off acid and fix a totally different metabolic problem.
Which perfectly tees up step 3. Looking at the bicarb, this is the kidneys territory, and here we use the ME part of Rome, metabolic equal.
Right, metabolic equal. In primary metabolic disorders, the bicarb and the pH go in the equal or the same direction. If pH is low, bicarb is low.
It's so clean when you break it down like that.
To visualize this without just, memorizing a bunch of arrows, think of the blood's pH like a chemical seesaw.
Okay, a seesaw.
On one side, you have the lungs, breathing heavily to physically blow acidic CO2 out of your mouth. On the other side, you have the kidneys, slowly dripping basic bicarbonate into your bloodstream.
So if the kidneys fail, let's say they just stop producing bicarb entirely,
Yeah.
that side of the seesaw drops.
Exactly. You have a primary metabolic acidosis. The seesaw is heavily tilted toward the acid side.
So to compensate, the lungs on the other side have to work twice as hard. They start breathing faster and deeper to blow off enough CO2 acid to try and level that seesaw out again.
Yes. And that physical overtime is exactly what you see clinically. If you have a patient in metabolic acidosis, you will see them taking these deep, rapid breaths.
Oh, Kussmaul respirations.
You got it! Kussmaul respirations. Their lungs are frantically trying to compensate for the kidney's failure.
That makes the clinical picture so much clearer. So we've used steps 1, 2, and 3 to get our primary diagnosis: respiratory or metabolic, acidosis or alkalosis.
Right, the foundation.
Now we hit a major fork in the road. And there's a very strict branching pathway here in the source material. You only move on to steps 4 and 5 if your primary diagnosis is metabolic acidosis.
And this right here is where so many students lose points on the exam.
I believe it.
If you diagnose respiratory acidosis, respiratory alkalosis, or metabolic alkalosis, you stop at step 3. You are done with the math. Do not pass go.
You just pick your answer and move on.
Exactly. But if you land on metabolic acidosis, you are obligated to proceed to step 4. You have to keep digging.
All right, so step 4 is calculating the anion gap. The formula is sodium minus the sum of chloride and bicarb. So Na minus parentheses Cl plus HCO3.
Right, and a normal gap is 10 to 12.
But let's look at the mechanism here, because I could do basic subtraction, but why do we care about this gap? Like, what is actually happening in the plasma?
So the anion gap is basically a measure of invisible troublemakers.
Invisible troublemakers, I like that.
Yeah, in normal blood, your positively charged ions, which is mostly sodium, should roughly balance out your negatively charged ions, mostly chloride and bicarb.
Right.
The small normal gap of 10 to 12 only exists because of unmeasured negative ions that naturally float around, like plasma proteins and phosphates.
But if you calculate the gap and it comes back at, say, 25 or 30...
Then something catastrophic is happening.
Wow.
A gap of 30 means there is a massive flood of unmeasured acids invading the bloodstream. These are rogue acids, things like lactic acid from severe sepsis, or ketones from uncontrolled diabetes, or, toxins from ingested antifreeze.
And these rogue acids are dumping hydrogen ions into the blood, right?
Exactly, which immediately attack and consume your bicarb buffer. As your measured bicarb drops, that mathematical gap between your sodium and your negative ions just blows wide open.
So finding an elevated anion gap is basically finding the murder weapon.
That's a great way to put it.
It narrows down exactly what is making the patient sick. You find the high gap, you start hunting for ketones, lactate, or toxins.
Yep. And once you find that high gap, you are forced into the final, most complex stage of the diagnosis. Step 5.
Oh, boy.
The delta ratio.
This is the algebra I was complaining about earlier. If there's a high anion gap, we must calculate the delta ratio to hunt for hidden concurrent disorders.
The math definitely looks daunting, but conceptually, it's just comparing two changes.
Okay, walk us through the formula.
The formula is the change in the anion gap divided by the change in the bicarb. Specifically, it's your measured anion gap minus 12 divided by 24 minus your measured bicarb.
Okay, so the numerator is just how much higher our patient's gap is compared to the normal 12.
Right.
And the denominator is how much lower our patient's bicarb is compared to the normal 24. We are literally comparing the rise of the unmeasured acids to the fall of the body's primary base.
That is exactly it. The underlying logic here is a 1-to-1 ratio. For every 1 unit of rogue acid added to the blood, let's say a ketone, it should consume exactly 1 unit of bicarb.
Makes sense.
If that 1-to-1 relationship holds true, your delta ratio will fall between 1 and 2. That means it is a pure, uncomplicated, elevated anion gap metabolic acidosis.
But what if it's not a one-to-one trade? The rules say if the ratio is greater than 2, a metabolic alkalosis is also present.
Right.
Let's break down the why there. Because if the ratio is greater than 2, the gap went way up, but the bicarb barely dropped at all. Why didn't the bicarb drop?
Because the patient's body must be hoarding or generating bicarb for a totally different reason.
Oh, interesting. Give me an example of that.
Imagine a patient who is in diabetic ketoacidosis. They are producing tons of ketones, driving the gap way up, but they have also been severely vomiting for 3 days, losing massive amounts of stomach acid.
And losing stomach acid causes a metabolic alkalosis, which raises the bicarb in the blood.
Exactly. They're piling an acid problem on top of a base problem. The vomiting is artificially propping up the bicarb level, masking how severe the diabetic ketoacidosis really is.
That is wild. So the delta ratio cuts right through that illusion.
It really acts like an X-ray for mixed disorders. Now consider the opposite scenario. The rules say if the ratio is less than 1, a normal anion gap metabolic acidosis is also present.
Okay, why would that be?
Because the gap went up a little, but the bicarb absolutely tanked. It dropped way more than it should have based on the unmeasured acids alone.
Which means the patient is losing bicarb through a secondary route. They aren't just buffering those rogue acids. They are literally draining bicarb out of their body.
Right, like through severe profuse diarrhea.
So it's a dual-threat acidosis.
Yeah.
2 completely different metabolic crises happening in the same patient at the exact same time.
Yeah. And a standard pH check misses this completely because the numbers just blend together.
Okay, let's pull this out of the abstract and put it into practice.
Right.
I'm going to walk through example 1 directly from the clinical notes to run all 5 steps in sequence. Listeners, picture this patient in your mind.
We have a 21-year-old with type I diabetes presenting to the ED with nausea, vomiting, and fruity breath. They are breathing deeply and rapidly. Their labs come back. Sodium 134, chloride 91, BUN 29, pH 7.29, PCO2 22, potassium 5.8, bicarb 13, creatinine 1.6, and a blood glucose of 780.
Okay, hold on. Let me interrupt this massive data dump. You threw in a BUN of 29, potassium of 5.8, and creatinine of 1.6. Those aren't anywhere in our 5-step formula. Are those just like exam distractors designed to panic a student?
Oh, absolutely.
I knew it.
The pantsy loves to throw a full chemistry panel at you just to see if you bite. You have to learn to filter out the noise. For the acid-based diagnosis, ignore the BUN, potassium, and creatinine. Just focus purely on the pH, PCO2, bicarb, sodium, and chloride.
Good to know. So glucose of 780, fruity breath. Clinically, we all suspect diabetic ketoacidosis here, but we have to prove it mathematically.
Right. Step 1, look at the pH. It's 7.29. That is below 7.35, so we have acidosis.
Step 2 and 3. Analyze PCO2 and bicarb. The PCO2 is 22, which is well below the normal 40. The bicarb is 13, well below the normal 24.
Both are low.
Yeah, both low. So they are moving in the same direction as our low pH.
And using the Rome mnemonic, that's metabolic equal. Since they are going in the equal or same direction, this is a primary metabolic acidosis.
And because the PCO2 is also low, that represents our seesaw analogy, right? The lungs are breathing rapidly to blow off CO2 and compensate. So primary metabolic acidosis with respiratory compensation.
Perfect. Now we hit our branching criteria. Since it's metabolic acidosis, we must perform step 4 and calculate the anion gap.
All right, sodium minus the sum of chloride and bicarb. So 134 minus 91 plus 13.
Let's see. 91 plus 13 is 104. 134 minus 104 gives us a gap of 30.
30. That is massively elevated above the normal 10 to 12. So we definitely have a flood of unmeasured acids in this case, ketones invading the blood.
And because the gap is high, we enter the final boss, step 5, the delta ratio. Measured gap minus 12 divided by 24 minus measured bicarb.
So 30 minus 12 on top divided by 24 minus 13 on the bottom. That gives us 18 divided by 11, which comes out to roughly 1.64.
Right. Now look at our logic rules. 1.64 falls between 1 and 2. It is a 1-to-1 ratio of acid added to bicarb lost. Therefore, this is a pure, uncomplicated, elevated anion gap metabolic acidosis. There are no hidden concurrent disorders like vomiting or diarrhea confusing the picture.
So the clinical suspicion is confirmed. It's classic DKA.
Exactly.
5 logical steps, and the clinical mystery is completely solved. But, we can't stop at one example. It's time to build that muscle memory.
Repetition is key.
We are turning the spotlight directly onto you, the listener. It's time for an interactive pop quiz using the rapid-fire cases from the source material. I am going to read the labs. I want you to hit pause on this deep dive, run the steps in your head, and then our expert here will break down the answer.
And really, don't just wait for the answer. Forcing yourself to run the mental algorithm under simulated pressure is exactly how you train for the boards.
Absolutely. Round 1, case 2. The labs are pH 7.29, PCO 258, HCO 322. What is the disorder? So pause the audio right here. All right, let's break it down.
Okay, step 1, the pH is 7.29, which is low, acidosis. Step 2, PCO2 is 58, normal is 40, so 58 is very high.
So the pH is low, the PCO2 is high.
Right, they are going in opposite directions. Rome tells us respiratory opposite. It's a respiratory acidosis.
Okay.
Then looking at step 3, the bicarb is 22, which is normal. The kidneys haven't started dripping extra base into the blood to help yet. So the final answer is primary respiratory acidosis, uncompensated.
And crucially, since it's respiratory, we stop there. No gap, no delta ratio.
Exactly. Don't do extra math if you don't have to.
Round 2. Case 6. Now this one is dense. pH 7.25, PCO2 25, HCO3 10, sodium 140, chloride 77. Evaluate. Take a second.
Okay, walk us through the mechanism.
Okay, step 1, pH 7.25 is very low. Acidosis, PCO2 is 25, which is low. HCO3 is 10, also low.
So both are going the same or equal direction as the pH?
Nope. It's a metabolic acidosis with respiratory compensation. Since it's metabolic, we have to calculate the anion gap. Sodium 140 minus chloride 77 plus bicarb 10.
So 77 plus 10 is 87.
Right, 140 minus 87 gives us a massive gap of 53. An absolute explosion of rogue acids. And because the gap is so high, we move to the delta ratio. Measured gap 53 minus 12 divided by 24 minus measured bicarb 10. That's 41 divided by 14, which gives us a delta ratio of 2.9.
And 2.9 is greater than 2. The gap went up by 41 points, but the bicarb only dropped by 14 points. The patient is holding on to bicarb somehow.
Interesting.
This tells us we have a mixed disorder, primary elevated anion gap metabolic acidosis, PLUS, a concurrent metabolic alkalosis.
So our patient is dealing with 2 opposing metabolic crises at the exact same time, like severe sepsis causing lactic acidosis while simultaneously vomiting profusely.
Precisely the clinical picture you'd expect to see with those numbers.
All right, final round, case 8, make it count. pH 7.28, PCO2 26, HCO3 11, sodium 129, chloride 100. Pause. Calculate the whole board. All right, bring us home.
Step 1, pH is 7.28, acidosis. PCO2 is 26, low. HCO3 is 11, low, equal direction. So primary metabolic acidosis with respiratory compensation.
Then step 4, anion gap, 129 minus 100 plus 11. 129 minus 111 is 18. The gap is elevated above the normal 12.
Yes, so step 5, delta ratio. 18 minus 12 divided by 24 minus 11, that's 6, divided by 13, which equals roughly 0.46.
0.46 is way less than 1. The gap only went up slightly, but the bicarb absolutely cratered.
Because they are losing bicarb from a secondary source, the answer is primary high anion gap metabolic acidosis, PLUS, a concurrent normal anion gap acidosis.
Wow.
Yeah, a dual threat acid crisis, likely involving both systemic acids and severe gastrointestinal bicarb loss.
We just took a highly intimidating wall of raw data and stripped it down to a completely logical mechanism. Let's recap the core algorithm one last time for everyone listening. You start by checking the pH to declare acidosis or alkalosis.
Right.
You use the Rome mnemonic, respiratory opposite, metabolic equal to find the primary offender and check the chemical seesaw for compensation. If and only if it is a metabolic acidosis, you calculate the anion gap to hunt for rogue, unmeasured acids. If that gap is high, you use the delta ratio to shine an X-ray on the underlying pathophysiology and expose hidden mixed disorders.
It feels super clunky the first 10 times you do it. I promise you, every practicing PA struggled with this at first. But doing these calculations repeatedly, forcing yourself through the 5 steps on every UWorld practice question, will build unbreakable muscle memory.
It really does.
By the time you sit for the PANT C, the numbers won't look like a math test anymore. They will look like a patient's physiology speaking directly to you.
You absolutely have this. And as we wrap up this deep dive, I want to leave you pondering something beyond just passing your boards.
Mm.
Think about the sheer elegance and really the desperation of the human body in these moments.
It really is a marvel of biological engineering.
The lungs and the kidneys are constantly performing this complex, life-saving calculus completely behind the scenes, adjusting breath by breath, drop by drop, just to keep a critically ill patient alive in a perfectly balanced state.
It's incredible.
We know what compensation looks like on paper now, but I want you to think about what actually happens in the trauma bay when those compensatory limits are finally pushed to their absolute breaking point, when the seesaw snaps, when the lungs can't physically breathe any faster and the kidneys have absolutely no bicarb left to give.
That's the scary part.
What does that unraveling system look like in the patient right in front of you? Keep that clinical reality in your mind as you prep for your exam. Until next time, keep studying and trust the process.